congratulating all of those individuals that were representing the division at AHA scientific sessions this year with moderating, inviting presentations, presenting original research, or otherwise participating. So congratulations to each of you in that regard. There were a number of late-breaking clinical trials and science presented, so I'll be highlighting a few of those. There were clearly many, many more, but let's kick this off, and please note my disclosures. So we'll start off with what was probably the most impactful and covered trial that was presented at AHA, had its own dedicated session, and was simultaneously published in New England Journal of Medicine, and that's the SELECT trial. So look at semaglutide and cardiovascular outcomes in patients overweight and obesity with cardiovascular disease, importantly, who did not have diabetes. So as background here, it's estimated that more than half the world's population will be either overweight or have obesity by 2035 using the classic criteria by body mass index. High BMI has been estimated to account for 4 million deaths globally in 2015. More than 2/3 of the deaths associated with obesity, elevated BMI, are cardiovascular disease. To date, though, up until the SELECT trial, really no lifestyle or pharmacologic intervention for overweight or obesity had actually been shown in randomized prospective studies, not observational studies, to actually reduce hard cardiovascular events. So there was very much the question about why overweight and obesity were cardiovascular risk factors, were they truly modifiable for reducing events. Now, the glucagon-like receptor 1 agonists, the GLP-1 receptor antagonists, have been studied extensively in patients with type 2 diabetes and shown to reduce major adverse cardiovascular events. So really the first medication in type 2 diabetes within trial meeting its primary endpoint, where there was a MACE reduction and even in some trials, all-cause mortality. So if you pull all these trials together, though, in patients type 2 diabetes, a 14% relative risk reduction for major adverse cardiovascular events, cardiovascular death, MI, ischemic stroke, with confidence intervals that were significant. Semaglutide did show, if anything, a slightly greater, larger hazard ratio, more on the order of approximately a 20% relative risk reduction. These agents do reduce body weight, a favorable, to begin with, effect in type 2 diabetes, but being studied in obesity actually had even greater reductions in body weight. But what had been unknown is whether these agents could actually reduce cardiovascular risk in individuals that do not have type 2 diabetes. So the hypothesis and design for SELECT was whether using the once-weekly subcutaneous regimen at a dose of 2.4 milligrams of semaglutide could, compared to standard of care, background therapy, reduce the incidence of major cardiovascular events in those who were overweight or obesity by body mass index 27 or above, who had pre-existing atherosclerotic cardiovascular disease, but did not have type 2 diabetes, or type 1. So randomized double-blind placebo control. It was an event-driven trial. It's powered for superiority. There were 804 clinical sites in 41 countries, really the largest study of GLP-1 receptor antagonists, one of the largest studies in obesity ever conducted. So here are the inclusion and key exclusion criteria. So 45 years of age and above, BMI 27 kilograms per meter squared or higher, and then established cardiovascular disease with at least one of the following. So prior MI, prior stroke, symptomatic pulmonary, peripheral arterial disease, need to have claudication with the documented Brachial index is less than 0.85, peripheral arterial revascularization or amputation due to atherosclerotic vascular disease. So known ASCVD, a secondary prevention population. Excluded though, type 1 or 2 diabetes, hemoglobin A1C 6.5 or above, regardless of whether you were clinically diagnosed with diabetes, treated with a glucose lowering agent. Heart failure could get in, but if they were class 4 heart failure excluded, a recent atherosclerotic cardiovascular event prior 60 days would have to wait to be beyond 60 days, a planned revascularization, end-stage renal disease or dialysis, history of pancreatitis, a malignancy in the prior 5 years, severe psychiatric disorder, or pregnant. So those were the key exclusion. So again, we're talking individuals 45 and above, known CHD, but these patients did not have diabetes, did not have an A1C that was 6.5 or higher, and had to have a documented BMI 27 or higher. Randomized 1-to-1, once weekly or matching placebo, subcutaneous injection, and followed out as long as trial would require, approximately 40 months median follow-up. So event-driven trial, patients who develop type 2 diabetes over the course of the trial could get open label use of drug to treat diabetes, but could not use a GLP-1 receptor antagonist, but other treatments could be started. Oh, I should also point out here, started off at low dose 0.24, and then is titrated to 0.5, 1.0, 1.7, and 2.4, and then sham dose escalation for placebo. And then once on the maintenance dose, maintained and matching placebo. So key endpoints. Time to first event for CV death, non-fatal MI, non-fatal stroke. So real standard hard MACE events. Confirmatory secondary endpoints using a hierarchical order, CV death, heart failure composite, CV death, or hospitalization or urgent visit for heart failure and all-cause death. And then supportive secondary endpoints, the expanded CV composites, looking specifically at non-fatal MI, non-fatal stroke, looking at the heart failure endpoint without CV death, looking at coronary revascularization or unstable angina, a nephropathy composite, and progression to avert diabetes or prediabetes using hemoglobin A1C criteria. And then looking at physiologic changes, body weight, waist circumference, hemoglobin A1C, blood pressure, heart rate, CRP for inflammation, and looking at the effects on lipids. So here's the key endpoints. So they powered this for a 17% relative risk reduction. The alpha is 0.25, and projected placebo event rate was 2.2% per year. And 17,500 patients and 1,225 positively adjudicated primary endpoints. So here was a kind of interim analyses, the hierarchical for the gatekeeping strategy to separate alpha spending. You'll see why this comes up important, is a hierarchical one. So once you didn't reach a secondary endpoint, you weren't supposed to, by p-value, look further in that regard, but certainly from an exploratory standpoint could. So you can see the one-sided and two-sided p-values that would be necessary to be considered significant, but for CV death, you'd have to be at 0.023 to go onto the heart failure composite and have to be significant there to go on to all-cause death. So the study was conducted between 2018 and 2021. You can see a little under 9,000 patients in each group. And here's the characteristics. So what I want to highlight for you, that the age approximately 62, very similar to secondary prevention populations, women representing only about 28% of those enrolled. Similar to other coronary disease population trials that enroll, but below what you would expect for coronary disease overall. For body mass index, the mean was 33.3, The proportion of patients 30 or above was 72, 71%, so means about 29% were BMIs below 30. Hemoglobin A1C, obviously part of the criteria, was 7.8, and there were about 2/3 of patients in that sort of pre-diabetes range of 5.7 to 6.4. Prior MI in about 3/4 of patients prior heart failure or current heart failure, but had to have not New York heart class in about 1/4. You can see systolic blood pressure for secondary prevention population, reasonably well treated, can see close to 90% on statins, not perfect, but reasonable for a large international trial. LDL cholesterol well below 100. Sure, it wasn't 70 or below, or even 55 as some guidelines would call for, but still pretty good and among the best we've seen in ASCVD enrolled population, and triglycerides in the 135 range. So, you can look at each of these and say, okay, pretty well background treatment on top of what we're now going to look at for obesity. So what was the follow-up here? The exposure was pretty similar to the two drugs. Withdrawal due to adverse events, though, or reporting adverse events and not getting follow-up, you can see was higher with the GLP-1 receptor antagonist. So 16.1 versus 7.8, but you can see other was a little higher with regards to placebo for, quote, lack of effect, a small rate of discontinuation. And so overall did not complete treatment through the course of follow-up, was 26.7 with semaglutide and 23.6 placebo. Now you can see the exposure by dose. So you can see with the up titration taking place and the matching placebo. So, almost all got to target dose of placebo, but not all, right? So you get some side effects just from placebo. But clearly some patients left on the lower doses couldn't tolerate the up titration due to mainly GI side effects in this regard. But, vast majority in both arms on the 2.4 milligram target dose. So 77% by week 104 of the semaglutide versus the placebo patients. So looking at this further as far as completing the trial and vital status, and pretty remarkable for such a large trial, vital status known in 94.4%. Follow-up duration, again, that 40 months plus or minus 9 months. Okay, so cardiovascular efficacy, primary endpoint, time to that first event of CV death, non-fatal MI, non-fatal stroke. So here we go. We can see the placebo arm, 701 events, 8% event rate. You can see how those curves advance from the time of enrollment. And then with treatment here, 6.5%. So, 1.5% absolute risk reduction, relative risk reduction, 20%. 95% confidence intervals as great as a 28% to as little as a 10% relative risk reduction. Two-sided p-value less than 0.001 for superiority. So we have both in absolute and relative terms, clinically relevant, statistically significant difference here. With notice how early the curves are diverging, right? We're seeing separation within weeks of these event curves, which is interesting. You're still in the up titration phase of the drug dosing. The weight loss hasn't come close to plateauing, but yet there's already event reduction. Okay, let's look at the primary endpoint across clinically relevant subgroups. So men and women, no heterogeneity there. If we look by age, perhaps some attenuation if those 75 and above, but there was not the confidence intervals overlap, no significant interaction. By BMI, interesting, less than 30, so 27 to 30, 30 to 35. If anything, perhaps the greatest effect. Notice, however, confidence overlap pretty substantially as we get above 45, but certainly it was not, the benefit was only confined to those that were, in obesity category 2 or 3 in that regard, and benefits regardless of whether that hemoglobin A1C was above or below 5.7, but no statistically significant heterogeneity or significant interaction p-value. So here's death from cardiovascular causes. This was the first confirmatory secondary endpoint, and you can see 15% relative risk reduction, but the confidence intervals do just ever so slightly cross 1, p-value of 0.065. 0.5% absolute risk reduction. It is interesting, the curves separate, kind of come back together. Remember, COVID was taking place during this trial, so who knows if that played a role, and then they sort of separate again and become a little more prominent there. So interesting in that regard, but that first secondary endpoint did not meet as the trial specified statistical significance. But let's keep going from a hypothesis standpoint. Look at the heart failure composite, and 18% relative risk reduction, 0.7% absolute. By confidence intervals did not cross 1. If p-values were provided, would be significant, but by how structured in this trial would be considered exploratory in that regard. If we now go to death from any cause, this is obviously the ultimate arbiter of benefit and risk. There was a 19% relative risk reduction. The confidence intervals do not cross 1. This is a 0.9% absolute risk reduction. NNT to save a life, a 111. Curves separate relatively early, do kind of work their way back, but never touch again, and then separate even further at 36 months. So, putting the stats aside, this is data suggesting that this is, life-saving in this type of group of patients, but did not reach the pre-specified statistical significance. Okay, so summarizing these secondary endpoints, you can see if you throw in revascularization, unstable angina, it's still a 20% relative risk reduction. For non-fatal MI, 28% reduction. Now, what's interesting, stroke trended less, but only a 7% relative risk reduction, non-significant. This is notable because in the type 2 diabetes trial, if anything, GLP-1 receptor antagonists have kind of shined around stroke risk reduction, but wasn't seen here in this population to the same degree. Heart failure hospitalization or urgent visit, relatively small in absolute terms, but 21% non-significant. Reduction, coronary revascularization, 23%, confidence intervals don't cross 1, unstable angina requiring hospitalization, less events here, about 13%, and then this nephropathy composite that was renal death, chronic replacement therapy, getting to a GFR less than 15, or the major driver of 50% reduction in eGFR or urinary albumin creatinine ratio getting above 300 milligrams per gram. And, that did have a 22% relative reduction. So not as robust as SGLT2 inhibitors, but significant in the standpoint of confidence intervals not crossing 1, but exploratory in that regard. Okay, what happened metabolically? Well, you can see the weight reduction here on the order of about 10% change in body weight, occurs over that first 26 to 39 weeks, and clear separation in the placebo arm, maybe a slight reduction in body weight, but on the order of 1% or less. Waist circumference also went down significantly from baseline and then maintained. And notice how long, right? You're not seeing this attenuation of the body weight effect or waist circumference effect. Lose that weight and staying on therapy, continue to have that off. So you can see highly statistically significant here, and the magnitude overall placebo corrected 8.5% difference in body weight and a 6.5 centimeter reduction in waist circumference. Now, if we look at hemoglobin A1C, and if you classify this as preventing type 2 diabetes, wow, this over 70% reduction, 73%. If you look at preventing, new onset prediabetes, 67% relative risk reduction. There was on the order of about a 3.3 millimeter HD, greater reduction in blood pressure compared to placebo. Hemoglobin A1C, 0.3 reduction. Look at HSCRP though, approximately 37%, 38%. Relative change compared to placebo. LDL really modest change. Triglycerides though more 15.6 in relative terms. So really interesting, very favorable metabolic effects, and then HSCRP, an inflammatory marker. Now, what about tolerability, serious adverse events, and otherwise? For reported adverse events, 33%. Versus placebo, 36.4. So significantly in favor of the drug improving clinical outcome. And this was driven, cardiac disorders from that standpoint, but even infections. So go figure. GI, didn't see difference from what they reported as SAEs. But when we go to adverse events leading to drug discontinuation, clearly big difference here, 16.6 versus 8.2. So about 8.4% in absolute terms. GI leading to drug discontinuation, 10% versus 2. Metabolism or nutritional, 1.2 versus 0.3. Now, what about things that were concerns in diabetes and GLP-1? So acute pancreatitis, no difference here, and very low rate. Gallbladder related just reaches significant at 0.04, but 2.8 versus 2.3, so about 1 in 200 difference. No difference in COVID. People had speculated protection, GLP-1s, kind of goofy. And importantly, for overall cancers, right? We certainly don't want to cause anything there. Now, you could say, well, obesity drives neoplasms, so why are we not seeing a decrease, and are there offsetting effects? But overall was neutral and safe over the course of the trial, and again, that median follow-up of about 40 months. So what drives the SAEs here, the infection, cardiac disorders, offset by the increase in GI effects with semaglutide. So puts this all into perspective. So to summarize, among patients pre-existing cardiovascular disease, overweight, obesity, who did not have diabetes and were on pretty good background therapy for risk factor control and secondary prevention, once weekly subcutaneous semaglutide 2.4 milligrams reduced the risk of cardiovascular death, MI or stroke, by 20%. With narrow confidence intervals. Benefits occurred early and was concordant across the clinically relevant subgroups, and each component of the composite endpoint being numerically reduced. There were no unexpected safety findings or greater risks of overall serious adverse events with this drug. The mechanisms of the cardiovascular risk reduction, lots of speculation could come from this. Was it all just directly weight reduction? Are there additional beneficial effects given how early this was seen? Is this just related to reduction of metabolically unhealthy body fat? Are there direct cardiac actions? Are there direct anti-cardiac effects or anti-inflammatory effects beyond the weight loss that we're seeing? So all of that can be speculated and debated, but certainly with this agent, specifically in this population, got our first demonstration of really clear clinical benefit with heart event reduction. So the first weight loss management therapy proven in a rigorous randomized controlled trial to reduce the risk of cardiovascular events, really establishing then, for the first time, the kind of definitive evidence that many have speculated but didn't have the definitive proof. Being overweight or obesity is truly a modifiable risk factor for cardiovascular disease, and that incremental benefits up and above what we already do for lipid therapy, what we already do for blood pressure control and other secondary prevention management strategies in this population, that for these type of patients, we can further reduce their cardiovascular heart event risks with the use of this agent. So this was published New England Journal of Medicine. At this point, I'd welcome any comments, questions, or thoughts regarding the SELECT trial. Feel free to just jump in. Let me ask you, Carol, what was your impression?
Well, we had the top line results a couple months ago, so we knew what it was going to show. And this is, I think everybody kind of expected this. At least I did.
Yeah, it's good to hear. I mean, I will have to say there was a lot of pre-seeing the results speculation towards, are we going to be disappointed that there'll be no reduction in cardiovascular and all-cause mortality, and we'll just have kind of a, because it was such a huge trial, got some non-fatal event reduction for a relatively expensive medication. So I think, there was a group of individuals kind of pleased and impressed that, there was a reduction in all-cause mortality, the additional benefits regarding heart failure, maybe to a certain degree, renal, that everything lined up, and that, pretty clean trial with regards to no unexpected safety issues.
That's one thing. Hi, Dr. Fonarow. We have a question here. Thank you for the presentation. At least for, I guess, kind of shifting the diabetic patients with cardiovascular disease, now with SGLT2 inhibitors and GLP-1 agonists, I guess in clinical practice, is there a preference of one, favoring one or another from your perspective?
Yeah, it's a really great question. Certainly, if you look at all the guidelines, with heart failure, the greater magnitude of benefit for those patients with SGLT2 inhibitors, if underlying chronic kidney disease, likewise. For those where it's more atherosclerotic cardiovascular disease, the GLP-1 receptor antagonist. But what I would say, and what is being increasingly looked at, is both, and that the therapies, can potentially be additive. We've certainly seen heart failure preserved to EF with obesity, that those patients, a great functional outcome improvement with GLP-1 receptor antagonists, seemingly additive on top of SGLT2. So I think that's going to be where the line of research really goes. And the question in the chat that I'll also answer: has there been longer term follow-up? So do we really know? Now, most of the trials that were done did not have follow-up as long as this within trial, but we've certainly seen large observational studies since these agents have been available. And some of the trials where they've done extended follow-up, looking for mortality, and there has not been sort of late unexpected events that have occurred. A lot of the follow-up was along things that are going to be emergence of, concerns were around pancreatic cancer, gallbladder issues, malignancy, and for the most part have been rather clean in that regard. So, likely this is going to be, an enduring effect. What clearly happens, though, somebody stops the medication regardless of the duration they're on, you will see them regain weight, maybe not back to baseline and not like with the rebound effect, but there's clearly attenuation. So it's not as if a complete reset and the effects are enduring or have a legacy effect with regards to the weight loss. Individuals start regaining weight and the cardiometabolic effects will start to reverse. Okay, so
hey,
thanks for that.
Can I ask one quick question?
Sure.
Any thoughts on like prescribing patterns after this in terms of cardiologists? I feel like we're obviously very comfortable prescribing SGLT2s, but the next step in terms of managing this medication?
Yeah, thanks for that question. I think, at least the thought leaders and experts have said, okay, it's clearly 100% of cardiology drug now, and anybody caring for patients that have atherosclerotic cardiovascular disease have to be well-versed in prescribing this and being the one that prescribed this, that passing this off as, we'll refer back to primary care or endocrine doesn't fit now that it's hard about reduction. And again, these aren't patients even with type 2 diabetes. It's not this question, how am I going to manage their other medications in that regard? But I'd say even for those patients now that we have heart failure evidence that, need to get comfortable with. And it's pretty straightforward to prescribe and educate patients. And it was cardiologists largely running this trial. And I think you'll find being able to prescribe this is pretty straightforward. Just have to get kind of used to it. And it is a discussion with patients. And then there will, without a doubt, be these issues about insurance coverage, access, out-of-pocket expenses. It will take time for a shift in the mentality that this is not just medications that are being used for vanity purposes or for type 2 diabetes, but as cardiovascular event reduction. So that's going to take some time. So there will be barriers that you encounter going forward in the short term that will be worked through. So we need to view this as a cardiovascular protective drug that cardiologists should be prescribing and providing to our patients, given the improvement in outcomes. Now, from the data, can you really pick out who's going to have the largest benefit? It was pretty similar across the clinically relevant subgroups. So some of it will be, well, those patients who are at higher risk are going to derive the greatest absolute benefit. Cost effectiveness data will need to come through, but I think you're going to see a shift to where, there starts to be better insurance coverage for those. It may very well be confined to those with obesity plus underlying atherosclerotic cardiovascular disease and not being extrapolated to those with obesity, but without underlying ASCVD until further evidence emerges. So thanks for all the questions. Yep.
At the 2-year mark, since there was a similar number of patients with COVID, the lines came together for death from CV causes and heart failure. Are there any additional positive explanations?
You could think that, not that we're provided, but I think there'll be some additional analyses. You see, there's sort of trends come together. That's not that common in clinical trials. It could be the duration of follow-up given the different countries that came in, but COVID is really the only one that I've heard that kind of makes a little bit of sense. And we've seen COVID affect a lot of clinical trials with regarding to event ascertainment and hospitalizations and, in that period, and then there was a catch-up period afterwards. So hopefully there'll be some additional analyses that will be insightful, Henry, but it's, a really interesting part of this, but I don't think changes the overall interpretation of the trial. So interest of time, let's go on to the next study, and that is Orbita-2. Orbita-1 certainly captured a tremendous amount of attention and was followed up with the Orbita-2 trial. Notice, the reference here is to a placebo-controlled trial rather than sham-controlled, which is often the terminology used. Stable CAD guidelines give a class 1 level of evidence A recommendation in patients with refractory angina despite medical therapy with significant coronary artery stenosis amenable to revascularization. Revascularization is recommended to improve symptoms. Notice nothing about reducing MI, reducing cardiovascular death, reducing all-cause mortality, because clinical trials have not shown that. But, the reduction in symptoms, those studies were all, unblinded, where the patient knew how they were assigned, the clinician was aware of how they were assigned, and speculation became about whether could this all just be a placebo effect. If you look at the number of anti-anginals at the time of elective cardiac catheterization, there are a number of patients that are on 0 or just on 1. About 36% on 2, and relatively few on so-called maximal therapy of 3 or more. So have a fair number of patients that are undergoing cath and revascularization that, may not be exactly on maximal anti-anginal medications on top of their ASCV care. So Orbita looked at PCI plus guideline-directed anginal medications versus guideline-directed anti-anginal medications alone, and truly had sham control, referred to here as placebo. There was a trend for the primary endpoint, which was change in exercise time. It was only, though, a 16.6 second difference, and it was not statistically significant, and that difference is well below what you would get with a single anti-anginal medication. So the conclusion from Orbita was on background of anti-anginal medications and ASCVD meds, that the addition of PCI over placebo control, that you could not demonstrate symptomatic benefit, and led some to speculate that all of the benefit, even on no anti-anginal medications, a PCI was entirely illusory and entirely just placebo effect. And look back, and there really had not been a demonstration of symptomatic improvement that wasn't influenced by the knowledge that you just had a really nice, expensive procedure done by some really nice interventionists, and you all expected, major benefit to be demonstrated. So Orbit-2 was designed to address this issue of whether, PCI on top of really essentially no anti-anginal medications with patients with rigorously, as best as the investigators could define, were truly having ischemic mediated angina symptoms. So Orbit was single vessel only, but Orbit-2 allowed single or multi-vessel disease. Ischemia evidence, was mandatory for all stenoses, regardless of severity in Orbit-2. The primary endpoint was angina symptom score, that they also did collect exercise time, in contrast to Orbita, where it's exercise time alone. Follow-up duration, Orbita was 6 weeks, and then you could cross over. Orbit-2 was 12 weeks. And importantly, Orbita, you were on guideline-directed anti-anginal medications, and it was a mean of 3 at randomization. So it was looking at the incremental benefit of PCI up and above, a mean of 3 anti-anginal medications, and didn't show a difference. But with Orbit-2, it was without anti-anginal medications. If they had been on them, they were washed out. If they were on an anti-anginal medication, basically was used for other purposes as well, switched around to something that didn't have anginal properties, another antihypertensive, for example. So really to look at, compared to, just being on background atherosclerotic cardiovascular disease meds, whether, PCI up and above sham had any symptomatic benefit. So does PCI without anti-anginal medication improve angina compared to placebo? So, if no effect whatsoever, we would say that, the symptom control indication for PCI would be very much in question. If we do see benefit, hopefully we would expect it to be, large and equivalent to 2 or 3 or 4 anti-anginal medications, but this is what the trial was designed to look at. So inclusion criteria, you had to have angina or angina equivalent symptoms, had to have severe coronary stenosis in 1 or more vessel, had to have evidence of ischemia on stress imaging or invasive physiology, and for each of the lesions. They did symptom questionnaires. The anti-anginal medications were stopped. There were daily frequency on a smartphone app, and you had 24/7 access to the team. Were followed for 2 weeks. Then a pre-randomization visit, did your symptom questionnaire, did an exercise treadmill, dopamine stress echo, and again, this is off anti-anginal medications. Or at the randomization visit, you had your research angiogram, IFR, FFR. You then were isolated, so you couldn't tell whether you're getting your PCI or the placebo PCI. And your follow-up assessment phase, your daily anginal frequency, again, you're off anti-anginal meds, you're followed for the 12 weeks, and you got your follow-up assessment, symptom questionnaire, exercise treadmill test, dopamine stress echo. Here's the smartphone application, basically asked each day, did you have any angina? How many times did you have angina? And so this angina score, they construct the daily anginal score of the episodes, and also, looked at, did somebody need to cross over, that their pain was so bad they needed anti-anginal medications, and then of course, were you having ACS or death, or totally unacceptable. So here's the primary endpoint in the increasing units of the episodes of angina, and then anti-anginal medications, and this point score, and getting all the way up to 79, which is death, 78 is acute coronary syndrome, 77, unstable angina, and down as low as, totally green. On no meds, doing great, no angina at all. So, by their sample size calculation, they expected minimal detectable effect of 2 anginal symptoms, standard deviation of about 6 anginal symptom scores. They were powered at 0.05 and 80% power, requiring 284 patients. So this is how they were powered. Here's the study flow. So, had to assess 900 patients for eligibility, 439, could be enrolled in the trial. There were 301 that were randomly assigned. You can see the different reasons. Some got referred to CABG, some were totally asymptomatic or had total occlusions. And so you got 151 allocated PCI and 150 to placebo. And you can see, fantastic job by the team, right? You only had 2 not undergoing the PCI in the PCI arm and the sham arm, and everybody followed by intention to treat analysis. 12 weeks didn't lose anybody to follow up. Really good. So here's their age, 79% male, hypertension, and 2/3, about a quarter diabetes. With some little differences here, just given the numbers, but overall. In Canadian Cardiovascular Society angina category, so class 1, relatively few, class 2, about 58%, and 36 and 41% that were angina class Canadian Cardiovascular class 3. Duration that they've had angina was 8 months for the median there. 1 vessel disease in 80%, 2 vessel and 20%, and very few 3 vessel. Quantitative coronary angiography diameter shown here, the FFR findings, so 0.61, 0.65. The length of the stent in the PCI arm, obviously there's not a length in the sham arm, and stent diameter 3 millimeters, total length 42, IVUS in 69%, post PCI FFR 0.89, IFR 0.93. So here's graphically displayed the primary endpoint of the angina score. So you can see, look at that placebo effect as far as angina free on no anti-anginal medications in close to half, not quite. Angina, but not on anti-anginals, but with a pretty low point score and a little more. And you don't get into that yellow zone until you're, somewhere around 70% of patients being pretty well controlled. And then relatively few with heart events or adverse events. And requiring anti-anginals, but a little higher in the placebo versus PCI arm in that rate. So PCI improving anginal symptom score, OR of 2.21, this did reach statistical significance. So a mild or modest effect that you could describe, but was statistically significant, was detectable. PCI is not just placebo. It does improve symptoms in a proportion of patients. So this is looking at frequency here, and you can see PCI versus placebo, pretty large placebo effect, over 50% here by episodes of angina, but clearly a difference between PCI and placebo. Anti-anginal use, so majority of patients, 0, but a little higher in the placebo arm, but, didn't reach statistical significance. So, didn't really have to change your med use, but again, there was a little more symptoms in that arm. Adverse events, so unacceptable angina, only a single placebo patient, none in PCI. The acute coronary syndrome, low, but 4 and 6. And no deaths in this arm over the 12 weeks. So, obviously not powered for clinical events, not much going on here, but interesting, the sham PCI arm, only a single patient having such unacceptable angina over the 12 weeks. They're like, give me those anti-anginals. Canadian cardiovascular class did improve in the PCI arm more than the placebo arm, so this reached statistical significance. The exercise time by modified Bruce was significant. This is 59.5 seconds. For those of you aware of kind of beta blocker nitrates, calcium channel blockers, the improvement in exercise time with those were usually around 60 to 120 seconds in the various placebo-controlled trials that were performed. So, on the order of what you'd expect with a single anti-anginal medication for improvement in exercise time. So, interesting when you think about that, far less than many may have imagined, but was statistically significant. So looking at a variety of secondary endpoints of Seattle Angina Questionnaire frequency, physical limitations, stability, quality of life, freedom from angina, the 5D, the visual analog score, and then a stress echo score. These were significant. So could definitely say concordance with regards to the secondary endpoint. So the conclusions here from ORBITA-2 and stable angina, evidence of ischemia without anti-anginal medications with predominantly one or two vessel disease. PCI compared to placebo control, improved the angina symptom score, reduced angina frequency, increased exercise capacity, all modestly, and improved quality of life. It was seen very quickly, so immediate. It was sustained over 12 weeks, was consistent across endpoints, but far smaller than comparable unblinded data, and importantly, without that true placebo control. And we see in the placebo PCI arm a pretty significant response that was placebo related. So, very interesting findings put in context, really the first placebo-controlled trial to demonstrate efficacy of PCI for angina relief. As a procedure, it's feasible, and the symptoms that reduction occur that are up and above the control arm. Certainly, you can manage patients if the patient was absolutely against any anti-anginal medications. You could get some symptom relief with PCI. But of course, if you're on anti-anginal medications, it is still not yet proven that up and above that you can get further symptom relief. And certainly large trials have shown no reduction in MI cardiovascular death or all-cause mortality. So this was published simultaneously in New England Journal of Medicine, and welcome thoughts or comments and perspectives regarding ORBITA-2.
Greg, thank you so much. Quick, just curious about your thoughts. Do you think this will change practice and you'll see people offering PCI instead of medical therapy and patients? And do you think this will ever actually make it into some guideline as an acceptable treatment for angina, in patients who just don't want to be on medications?
Yeah, I think there could be that option for patients with contraindications or intolerance of medication, as an alternative at some sort of kind of lower level. I think when you think about it, from if we put a value proposition in there compared to a $40 a year generally well-tolerated medication, to undergo a PCI is, not a great value proposition. But I do think it opens the door for regards to, having evidence of symptom relief. But I think in general, the guideline primary pathway would be trying your anti-anginal medications, and then if angina is not well controlled, to proceed. So I think it'll kind of reinforce existing guidelines, but with a little more strength that, there is a symptom relief component and improvement in exercise time that's clearly been demonstrated to be up and above a placebo effect for PCI. So I think it's reassuring that it's not just all, our observational expectations, that there is truly a, ischemia and symptom relief component here. Okay, so we spent a lot of time on those two trials. I'm going to just really quickly do Artesia to wrap it up, and I'll send out a couple other trials via email. So Artesia was apixaban for stroke for prevention of subclinical AFib. And this is a true dilemma for us, right? We detect for those with implanted devices or continuous monitoring, those that are having subclinical AFib, brief asymptomatic episodes, minutes or hours. There's some evidence that are increased risk for stroke, but we've not had evidence that anticoagulation can actually lower that risk. And so the value of oral anticoagulation is really not known. And prior study that was done actually showed a trend but didn't reach significance. So this was looking at apixaban versus aspirin. These were patients that had to have CHAD's 2-VAS score of 3 or higher, or advanced age or history of stroke with implanted pacemaker, defibrillator, cardiac monitoring, where they had these spontaneous subclinical episodes 6 minutes to no longer than 24 hours, followed for a primary endpoint of stroke or systemic embolization. Major safety endpoint was major bleeding, followed for 3.5 years. And, you know, apixaban versus aspirin, so not placebo control. And you could argue about, you know, the use of aspirin in these patients. How effective or would that lead to bleeding? 4,000 patients randomized, good follow-up, 22% died, only 2.9% withdrew. Primary intention to treat analysis looked at bleeding. There was on treatment analysis. So mean age of 77, CHAD's 2-VAS close to 4, a lot of comorbidities. And then you can see with regards to baseline before randomization, a fair number had been on aspirin. You can see a lot of the episodes were pretty brief, right? So, you know, the number that were 12 to 24 hours were just about 7%. So a lot of these were less than 6 hours. So the primary endpoint, stroke or systemic embolization, aspirin versus apixaban, 37% risk reduction, statistically significant. So can we prevent stroke or systemic embolization in this group? Yes. In the absolute terms, though, notice this is rather modest effects. So, you know, talking about a fraction of a percent, approximately 0.5, but was significant. Total strokes, you can see this was reduced. Ischemic stroke reduced. Hemorrhagic stroke was not increased with apixaban. And for disabling strokes, 3 or 6 was reduced by about 50%. Notice, however, for CV death, no difference there. Major bleeding was increased, though, and in absolute terms, this is a little higher than the reduction in stroke. But fatal bleeding, notice that, you know, 0.1 versus 0.16. So we're not seeing difference. Symptomatic ICH, not different. Transfusion requirements, not statistically different. But this major bleeding was 1.53 versus 1.12, 36% higher. So, you know, using by intention treat. The conservative measures for most bleeding, maybe a transfusion, but needing like surgery or dying, you can see, you know, really not a big difference there. So the benefits and risks, there's clearly risks, right? More major bleeds, but, you know, it's a trade-off. 4.6 fewer strokes or emboli, 4.1 major bleeds. So, you know, would you rather have a major bleed or would you rather avoid your stroke or emboli? So need to have a patient discussion, but, you know, clear evidence we could reduce it. What we'd like to find is there's some group where those benefits outweigh the risks, or can we get an agent that actually would help us achieve the same stroke reduction without bleeding? So the conclusions here are 37% relative risk in stroke or systemic embolization, fatal and permanent disabling strokes reduced 49%, but apixaban relative to aspirin increases major bleeding, but no increase in fatal or intracranial bleeding. Anticoagulation should be considered in these patients, but you really do need to have a patient-centered discussion rather than considering this a mandate. And this is in a background of, you know, CHAD's 2-VAS score of 3 or higher. A meta-analysis was done with the prior studies, and you still see a significant effect with regards to stroke and systemic embolization being reduced, but also a significant effect with increase in bleeding. So this is a risk-benefit ratio, and hopefully we'll get smarter to pick out a subgroup of patients that derive even greater benefit. This was published New England Journal of Medicine as well. So with that, we've got maybe a minute or two for any comments or questions with regards to this study.
We're not talking about Verve.
I know wasn't going to include that, but obviously really, interesting as a kind of phase 1 sort of study of CRISPR-based gene editing for PCSK9 inhibition. And you were, great moderator of that session. And certainly there are a couple others, DAP-MI and some other intriguing studies in LP(a) reduction, with small interfering mRNA. So I think a lot of exciting things on the horizon, but we'll need a lot more robust data. And even here for this study, do you think, open for further consideration? So I think some additional randomized trials in broader patient population will be helpful. But, this remains this dilemma, and, we're seeing more and more of these patients where the question is, what do I do? Am I at increased risk of stroke? How can I mitigate that risk? When seeing these rather brief and subclinical episodes. And I think this provides us, useful data in that regard to have patient-centered discussions.
Would have been nice, great overview, Greg. Yeah, I do wonder about particular artesia, if you had obviously you could have a utopia sort of set up. It would have been nice to have an intermediate 2.5 BID arm if you're already comparing it to aspirin, which is considered, inferior to high CHADS vascular cohort like this. It would be nice to see that intermediate. We know a lot of the other sort of ACS antiplatelet AC combos like Pioneer AF and Augustus, they all experimented, or also they randomized different arms of modified doses. So that would have been nice to maybe tease out a better risk-benefit ratio. So
yeah, whether a third arm like of antiplatelet therapy with 2.5 BID.
right.
You could have 2.5 BID if but I will argue, the rivaroxaban data for secondary prevention, right? It wasn't exactly this group. You didn't really see a lot of stroke prevention there. So you do have to kind of wonder of the kind of lower doses DOACs. I will say, the thing that opens the arm though of a trial that it won't have time to go through, but the factor 11 inhibitors may actually hit a sweet spot where you will still get the anticoagulation effects that are as large, but can dramatically reduce the risk of bleeding. And so here for the bleeding risk compared to rivaroxaban, a phase 2 study stopped early due to this, clear reduction in bleeding risk. And this is given, essentially as a 3 or 6 month dosing as a monoclonal antibody. So we may get into where we've got anticoagulation options that can lower the bleeding risk, but still maintain the anticoagulation benefits that the DOACs do. So we may emerge in an era where our therapeutics can get us into a far more favorable risk-benefit ratio. Obviously, we have to see that the stroke reductions are as larger with this, and those trials are ongoing. But we're entering an interesting era where these factor 11 inhibitors may get us into an even better spot for safer and or even more effective anticoagulation. So, stay tuned as we get more and more data here with that regard.
Yeah, speaking of factor 11 inhibitors, we're going to be a site for Librexia ACS, which is going to look at milvexian. So in ACS, it's going to be a very hard high-risk cohort to recruit, but because a lot of the triple therapy kind of concept might be daunting, I think, to patients, but we'll see how it goes. So yeah, that is certainly an exciting class of drugs that, like you said, brought up a lot of attention. So
yeah, and there's the Lilac trial looking at it for AFib. So we're going to get a lot of really interesting data around the corner, and great that UCLA is participating. So with that, I'm going to thank you all for participating in this conference today. I'll send out a PDF of all the slides that were presented, as well as one other clinical trial. And again, congratulations to all the faculty and fellows that participate in the AHA scientific session. So thanks so much.
Thank you, Greg. Thank you.
Thanks, Greg.